All right, so we'll start it today. We'll wrap it up next week. Also next week, I think I had mentioned that the folks from the FSRC were going to be coming out. They're coming out next week, next Wednesday actually. So just to note, they are coming to talk to you guys in particular. And then, so it's next week. Then the week after is Thanksgiving week. Wow. Semester has flown by. The year, to me, has seemed to fly by. Anyway, so this chapter is all about airway clearance therapy. You may also hear this referred to as bronchial hygiene therapy. It's everything related to airway clearance minus suctioning. We already talked about suctioning with airway stuff. So this is not necessarily suctioning per se. It's assisting the patient in being able to clear his or her own secretions. All right, so these are non-invasive techniques. When you hear the word non-invasive, what does that mean to you?
Non-surgical.
Non-surgical.
You don't go in.
Not necessarily going in the body like you would with a suction catheter or a needle, something like that. So these are all non-invasive techniques, non-invasive ways to assist in removing secretions from a patient. That, of course, getting the secretions out will help them improve gas exchange and be able to oxygenate and ventilate better. Many types of techniques that we will talk about today as well as next week. But I did want to mention, kind of before we get into it, that just because there's a technique we would discuss with this chapter, not every one is going to be appropriate for every single patient. There are certain things that are unique about each technique and each type of therapy that maybe one patient would benefit a little bit more with therapy A, and a different patient might be able to benefit better from therapy B. And I'm not going to list these in order as far as this is what you should do first, second, third. It really depends on the patient and what the patient's ability to tolerate, what the patient's ability to do, patient maybe position that we can place the patient in as far as what particular therapy we're going to choose. So when I say evidence-based, these are things all based on evidence, things that have proven to work or proven to be effective for certain patients in certain situations, maybe with certain conditions. But before we get into those techniques, just a quick review about normal secretion production, normal airway clearance. Normal airway clearance does require a patent airway. When you hear the word patent, what does that mean to you? Open, a patent airway, a patent bronchial airway, a patent trachea. We would talk about ET tubes and about how an ET tube could get blocked or occluded. Again, we want a patent ET tube, one that's open, one that's clear. So again, for normal airway clearance, it does require a patent or open airway, a functional mucociliary escalator. Remember the cilia moving in a wave-like uniform fashion, pulling secretions forward, pulling them up into the airway. Adequate hydration. I'm not going to go into all that thing about moisture again, but without adequate hydration, what would happen to the mucus, or what would happen to the moisture in our airway? It would become depleted. Cilia would get stuck. Cilia wouldn't be able to move the way they're supposed to move. All that's great to have, but if the patient can't or won't cough, then all of this, I don't want to say is pointless, but all of this will stop and limit the ability for a patient to clear secretions. The patient does have to cough, and we always have to encourage them to cough. Anytime you provide this type of therapy that we'll talk about today as well as in the next week, anytime you perform airway clearance, and I'll say that universally, airway clearance therapy, please don't forget, final step, ask the patient to cough. See if they can clear secretions. I remember when I used to do clinicals with students, and they'd go in to perform airway clearance therapy, and they would do a perfect job, and they would do everything great, and now we're documenting what they did, and it would always drive me crazy, and I purposely would not remind them on purpose. And so they're in there doing airway clearance therapy. They're doing assessments before and after therapy. They're listening to breath sounds. They're coaching the patient on how to do the techniques that we'll talk about beginning today. When we would document and chart, because I would have to chart on behalf of the student, but as I'm putting things in, the student's giving me the information to document, we'd get to cough. And again, remember, I purposely wouldn't remind them. At least half the time, well, they didn't cough. And I make a big deal about it. I'd step away from the computer terminal and I turn, well, what in the H did we just do? Right? Airway clearance, bronchial hygiene. Yeah, and you didn't have them cough? Oh, was I supposed to? Yeah, why don't you go back into that room, and again, I made a big deal about it. Go back into that room and have that patient cough. Yeah, that was 20 minutes ago. I don't care. Go back in there. We have to document that. Somebody's going back later to look and see what therapies were performed to this patient. And obviously this therapy is supposed to lead to a cough, hopefully airway clearance. Hopefully I can document that they're bringing something up. But if nothing else, I still want to be able to say they had a non-productive cough. And so always make sure, anytime they're doing the therapies that we'll talk about from this chapter, always make sure you have them cough. Mucociliary clearance does occur from the larynx all the way down to the respiratory bronchioles. What's the importance of the respiratory bronchioles? What does that area begin? Gas exchange. Respiratory bronchioles on down is where gas exchange occurs. So all of this is right before the areas of gas exchange. Mucus is produced by several different things. Secretory cells, submucosal glands. Most of the mucus that's produced in our airway is coming from the submucosal glands, providing that mucus layer sitting right on top of the cilia. Again, between the cilia and that mucus layer is that watery layer that the cilia can clean themselves off with. Now, normally healthy individuals can produce anywhere from 10 to 100 mLs of mucus per day. That's normal. That's normal. Which is normally cleared by our own mucociliary escalator. Where we could expectorate it or we swallow it back, and we don't even realize, that sounds disgusting, I know, but we don't even realize that we do it, right? We're removing that stuff constantly. A cough, again, is one of the most important reflexes to aid in clearance of mucus. If we have mucus that's kind of stuck and accumulating, yes, I do need to have a big, strong cough. I do need to assist my patient in performing a big, strong cough to be able to clear that stuff out. The cough mechanism itself has 4 different components or phases. They are the irritation. That's the first one. That's the first step. There has to be that irritation, whether it's retained secretions, whether it's the tickle in the back of the throat, whatever the case may be. Maybe it's airway inflammation that's leading to that irritation. But number one, there does have to be that reflex that you're feeling, that irritation. The second one is inspiration. Now, I know you and I could inspire deeply right now, and that's great. What about grandma, 87-year-old grandma, weak as can be? Could she take a deep breath? Maybe, maybe not. But if she can't, guess what's going to be impacted? Her ability to cough and clear secretions, because it does require a deep inspiration. Now, after that deep inspiration, there is for a brief second compression, the compression phase, which is closure of the glottis. That allows the pressure to build up in our chest. So we can immediately follow with now an open glottis and the expulsion of that breath we just took in. And hopefully when we exhale, we blast out. Hopefully we're grabbing hold of that mucus that's been stuck, irritating our airway. And hopefully we're able to bring that stuff up. That's why you should always cover your cough. Look where it goes. All right, so the 4 phases of a cough: irritation, inspiration, compression, and then expulsion. Now, things that could lead to abnormal clearance, the inability to clear secretions, could be airway patency. If the airway can't remain open, that's going to be a problem. If there's problems with mucociliary function, the inability for the cilia to do what they're supposed to do. Strength of the breathing muscles, now that's going to affect inspiration. If the breathing muscles are not strong enough to take a deep breath in, then there is no way they're going to be able to cough and clear that out. Thickness of secretions. Now, I think it makes sense. If the secretions are really, really thick, really, really tenacious, it's going to be harder to get those out. With you and I, our secretions are probably fairly thin right now. If we get a chest cold or something like that, maybe they thicken a little bit, but still usually nothing overly dramatic that we couldn't handle. But with certain diseases and illnesses could lead to thicker mucus production, which for the normal mucociliary clearance system, the cilia, may have a hard time with that patient and their disease process that's leading to thicker mucus. And then of course the cough reflex or absence thereof can affect someone's ability to clear mucus. Now, if mucus is completely blocking an airway, we would consider that a full obstruction. Mucus plugging, which could then cause the distal air to eventually become reabsorbed and then atelectasis to occur. This chapter does kind of a little bit tie into the previous chapter that we talked about with lung expansion. Partial obstruction, of course, can restrict airflow, can increase a patient's work of breathing, giving them the sensation of dyspnea, etc. Could lead to air trapping, which in turn would lead to lung overdistension, maybe even ventilation perfusion problems. And we will actually talk about what VQ means, ventilation perfusion, more next week. I was looking, what am I talking about with you guys next week? What's our next section? Actually, the very next chapter in cardiopulmonary A&P is on VQ, ventilation perfusion. And of course, as we said numerous times, if a patient has retained secretions, that can of course lead to different sorts of respiratory infections or pneumonias, things of that nature. All right, so with mucus production, with increased mucus production from someone being ill or sick, if we can't clear it and it stays retained, guess what happens in our airways? Inflammation. White blood cells, leukocytes will begin to go to that site. With retained secretions, of course, that could lead to lung infections. Lung infections lead to the production of more mucus. And you can get this nasty cycle going back and forth until we can do something to help clear that mucus. And that's what this chapter is all focusing on, the ability to help a patient clear this mucus. All right, so indications for airway clearance therapy. Acute conditions such as a patient with copious secretions. The word copious, what does that mean to you? A lot. Lots of secretions. Maybe the inability for a patient to mobilize their own secretions or that their cough is ineffective. Chronic conditions such as cystic fibrosis, bronchiectasis, just to name a few. Both of those illnesses lead to increased mucus, thicker mucus, mucus that's more prone to get trapped and stuck in their airway. A rare genetic condition, ciliary dyskinetic syndromes. This is like I said, genetic condition, so it's something one is born with. There's nothing you could do to avoid it. You're born with it, and it causes your mucociliary clearance system to be faulty. It causes the cilia to become faulty. Either the cilia is not going to be present in adequate quantities, it's not going to move in uniform, they could all be moving the wrong direction or opposite directions from each other, so it's hard for the mucus to be brought up for a patient to be able to cough or clear their own secretions. And anytime I can get COPD. All right, with COPD, and again, not to get into that illness because that's a whole chapter, you guys heard me say this the other day, whole chapter next semester. But one of the issues with COPD is cough and increased mucus production. You know what awareness month this is? COPD Awareness Month, yes. Mic drop, absolutely. It's also Lung Cancer Awareness Month for anybody who's interested. All right, so general rule of thumb. Patients with copious secretions, by definition, 20 to 30 mLs per day. That's in addition to what you're normally producing. So again, if we're normally producing anywhere from 10 to 100 mLs, that's fine. This is in addition to what you're normally producing. So someone having copious secretions or unable to expectorate and clear secretions may benefit from airway clearance therapy, the therapy that we'll talk about in this chapter. All right, so determining the need. Effective airway clearance therapy does require proper initial as well as ongoing assessment. Just because today we feel the patient would benefit from this therapy doesn't mean they're going to need that same therapy 2 days, 3 days, 4 days, 5 days from now. Maybe it's for a short period of time. It might not be necessarily something that's going to be for an extended period. And that's what I mean by ongoing assessment. Let's continually reassess the patient and see, is airway clearance therapy, number one, is it working? And if so, do we need to continue it? If it's not working, is there another airway clearance therapy technique that maybe would work better for this patient in their situation? Knowing their history of present illness. Now I will say, and I'll use cystic fibrosis as an example, that too is genetic. CF is a genetic condition. That generally is something, airway clearance therapy is generally something that would continue, would never stop with someone with cystic fibrosis. They have airway clearance therapy performed on them from the day they were born, their entire life. Every single day they're having airway clearance therapy performed on them. So something like that might not necessarily be something that would transition to, okay, you don't have to have this anymore. A disease like that, a condition like that, it would continue. Physical findings such as a loose but ineffective cough, labored breathing, decreased breath sounds, bronchial breath sounds, coarse inspiratory or expiratory crackles, tachypnea, tachycardia, fever, perhaps from infection. All of those could be physical signs for someone that could benefit from airway clearance therapy. Of course, chest x-ray could show atelectasis, could show infiltrates. Did I ever use that word with you guys, infiltrates? In the patient assessment class when it came to x-ray? Did I use the word infiltrate? I'm getting a lot of head shakes, no. Infiltrate
Infiltration, blockage.
is an abnormal appearance on an x-ray that is white, but I have no clue what it is. When you're in clinicals and somebody says, hey, have you seen an x-ray like this? You want to sound really smart? You walk up to it, and to sound smart, you have to look like this. I see an infiltrate in the right middle lobe. Boom, mic drop. Get out of there really quick before they start asking additional questions. An infiltrate is just something abnormal, but it's white in appearance. It could be a pneumonia, could be an infection, could be atelectasis, but it's just something that's abnormal, but it's white in appearance. And so when you hear the word infiltrates, it's not us just kind of trying to sound smart and genius or anything like that. No, it's just there's something abnormal there, but I'm not sure what it is. Okay, maybe there's some further testing that has to be done to figure out, is it a pneumonia? Is it an infection? But infiltrate's just an abnormality, but it does appear white in color. All right, so here's really the different type of techniques. Not all of them we'll talk about today. So 5 general approaches can be used as alone or in combination with other therapies that are also on this list. So chest physical therapy, we'll get into that quite a bit today. So CPT for short, chest physical therapy, sometimes known as chest physiotherapy. Coughing and related expulsion techniques, including an MIE, which we will talk about on Monday. Positive airway pressure devices or positive expiratory pressure devices. We'll get into those quite a bit more on Monday. These could be vibratory PEP devices that a patient can perform with. High frequency oscillation devices, as well as mobilization and just plain physical activity. Just like I said with the previous chapter for lung expansion, getting the patient up and moving is only going to benefit their overall health, including, now that they're up and moving, maybe even helping them with airway clearance, because now that they're taking deeper breaths, that may help get some mucus moving. All right, so the first one, chest physical therapy, again, sometimes known as chest physical therapy or could be referred to as chest physiotherapy. But regardless, we call it CPT for short. CPT for short. Now, CPT generally includes postural drainage, as well as percussion or chest wall vibration. Percussion, vibration, will differentiate the two. They're basically the same thing, but we will differentiate how percussion is different than vibration and vice versa. All of these use positioning techniques of the patient, utilizing gravity to help us when it comes to getting mucus moving, and mechanical energy, whether it's from the percussion or chest wall vibration. We will actually manually strike the patient's chest with cupped hands, okay? Not a fist, we're not slapping, but with cupped hands, actually striking the patient's chest to try to move and shake up, jostle, whatever other adjective I can come up or adverb I can come up with, to get secretions loosened so they can get to the more central airways for a patient to be able to cough and expectorate to bring up. All right, so postural drainage, that portion of CPT, postural drainage, is using gravity to our advantage by positioning the patient certain ways. And again, position the patient not for long, 3 to 15 minutes, maybe even longer in certain situations with certain patients who can tolerate it, but putting them in various positions for short periods of time to let gravity help us. Again, if I had, for example, I don't want to dump my water. If this is mucus and I want to get it out, how should I turn it?
Upside down.
Should I turn it this way? Is that going to get the mucus out? No, turn it upside down. And that's using gravity to allow that to fall. The same thing here with postural drainage. Now, all these numbers, what do these numbers represent? Lung segments. And we have approximately 10 lung segments in each lung. So for example, the right upper lobe, there's 3 segments. Again, kind of got to look down here. There's others, again, depending if you turn the patient around versus anteriorly, how you're going to see them. But regardless, maybe we're told to drain the, apical segment of the upper lobe. We need to know how to position the patient. Or the posterior basal segment of the right lower lobe. We have to know how to position that patient, okay? So posterior basal segment, that's down here in the back, right? And so just think about my analogy here. If we're talking about lobes or segments that are really, really low, how do you think the patient should be positioned? Shake them like hell and get that secretion moving. Okay. I'm not sure what they were doing in this picture, but I see this picture, I can't help think of postural drainage, right? Postural drainage. So, for example, the posterior basal segment of right or left lobe, how should the patient be positioned? Notice my picture here. Patient is positioned how? They're prone, they're on their stomach, they're on their chest, their head is down, or another way to phrase it, their feet are raised up. Again, approximately 18 inches, that's about a 30-degree angle that we place them in to allow these particular segments, posterior basal segments, to drain. Okay? And it's all the positioning of the tracheobronchial tree that I'm trying to get that stuff that were in those segments to drain out. What we're ultimately doing with all of this is to try to get these secretions into the more central airways so the patient could expectorate and bring the rest of that stuff up. But posterior basal segment position. Lateral basal segment. In this particular picture, it's of the right lateral basal segment. I didn't give you all of them here, but I'm giving you a few to look at. All right, so patient is lying on their left side. Again, what did I say we're draining? Lateral basal segment of the right lobe. So when you're wondering, well, something we're trying to drain is on the right, more than likely it's the right side that's going to be up and the left side is down. I'm never going to put the bad side, the affected side down, because how's that supposed to drain? It'd be like saying, okay, I'm going to drain the middle lobe here. Okay, that's not going to work. You've got to turn it to the opposite direction. So again, this is the right lower lobe, lateral basal segment of the right lower lobe. Patients lying on their left side, quarter turn up from face, so they're not lying perfectly prone. Quarter turn up from their face, held between the knees for comfort. Foot of the bed elevated, just like the previous picture. Again, to allow drainage of that particular lung segment. Give you another one. This is the superior segments of both right and left lobe. Now these are not the posterior basal. Basal was down lower. These are the superior segments of both right and left lobe. Patient is prone, so they're on their stomach. Pillow under the hips, bed flat. The feet are not elevated like they were for the posterior basal segment. Okay? All of these different positions. And how many lung segments are there? 10. 10 different lung segments. Again, every one of these positions is to try to drain one of these lung segments. So if this is the tracheobronchial tree, and you want stuff to come out of these particular segments, and again, it could be one segment, you have to make sure whichever you're trying to drain is turned opposite, so things could drain. You know, you're in the perfect position right now to drain what lung segments? You know, if you look at the tracheobronchial tree, I give you definitely 1, 2, and 3. Again, some of these are to the side, so you may have to be positioned on your side to drain those, but definitely number 1. Definitely number 1. So we're in the perfect position to drain that particular lung segment right now. But when you think about it, when folks get really sick and end up with retained secretions, where do you think the secretions end up going to? Gravity pulls them down, right? So generally, these are the ones that really are not too bad. They're probably the most open ones we have. It's the ones that are lower that can get kind of junked up. All right, so in case you're curious, all the different positions that a patient could be placed in, again, these are some repeaters from the previous 3 slides, or 4 slides. Depending what you're trying to drain, this is the position you're going to place the patient in. Again, for postural drainage. I think there's one more here too. Again, posterior basal segments, superior segments of the lower lobe where the bed was flat versus one where the feet were elevated. Again, letting gravity do its thing. Now, when you, and of course, again, this information that I'm going to eventually test you guys on, what test will it appear on? The final. So there's not test number, there's not test number 4, right? It's the final exam. How many questions did I say are going to be on the final exam that encompass chapters 43 and 44? About half of the test is coming from chapters 43, the one we did just Monday, and then chapter 44, the one we're doing today. 50% of the final exam will come from these 2 chapters. So make sure you are reviewing this stuff. I know it's just day 1 of us talking about this, but make sure you're reviewing this stuff to make your life easier leading into the final exam. Because yes, you can say, well, I'll just cram for it before the test. Well, good luck. All right. Knowing already half of the final exam is coming from chapters 43 and 44. So between now and whenever we test, which, what's today's date? December 2nd-ish, something like that. We've got about 3 weeks, right, for that test. But that gives you plenty of time to hammer this stuff in. I will also say, on the board exam, when they ask you questions about airway clearance, could they ask you questions about draining a specific lobe? Absolutely. And I'm dating myself when I took my board exam, again, totally different than what you guys take now, but we were in a room with probably another 100 people or so in a classroom setting like this, but much larger room, and it was blatantly obvious when the people that were taking the test that day got to the questions that dealt with positioning. Because when the question is asked, it's the patient is placed in such and such position, you'd see everybody in their chair going, okay. And then they sit there and write their answer down, okay? So make sure, right, left, prone. What's the name if the patient's going to be lying on their back? Supine. I'm not going to say patient lying on back or patient lying on stomach. No, I'm going to say supine, they're lying on their spine, or prone, they're lying on their chest and their stomach. So make sure you know those words. All right, so before I get to that one, does anybody remember when ketchup used to come in a glass bottle? Anybody remember when? Again, as the years go on, I get fewer and fewer people going, oh yeah, I remember that. Well, when we would have ketchup in a glass bottle, and especially if it was brand new, and you had your French fries, You wanted ketchup for your French fries, you open that lid, you turn the ketchup upside down, and what would the ketchup do? No quick. I'm staring at it. Nothing's happening to it, right? Now we have the squeeze bottles. You squeeze it and it all shoots out. But with those glass bottles, the damn ketchup would never come out. You turn it upside down using gravity to our advantage, nothing would happen. The ketchup wouldn't come out. But what would we do? We'd sit there and bang on the bottom of it. And sometimes that didn't even work, right? We have to get a knife and stick it up there to kind of loosen things up. But this striking component of the glass ketchup bottle, right, is what we use when we place the patient in the postural drainage position. We actually will then percuss on the patient's chest, not their bottom, like a ketchup bottle, but we'd actually percuss on the patient's chest or back, depending on what lobe or segment we're trying to drain. So, just placing them in those postural drainage positions alone is not going to be enough. You could sit there and go, patient, just lie in that position. I'll be back in about 2 hours and see if anything's drained by that point. Probably not going to drain. Again, the mucus could be so thick that it doesn't want to drain as easily. But that's where we have chest percussion or chest wall percussion with open fingers, cupped, closed fingers, cupped hands. No fists, cupped hands. And we will manually strike the chest. What you're doing is you're actually grabbing a little bit of air as you do that and applying that to the outer wall of the chest. Again, trying to do what? Loosen up the mucus. And so you'll perform it throughout inspiration as well as expiration. Patient's still going to patient, breathe normal, breathe normal. Let me go ahead and do this to you. Perform this rhythmic percussion to the chest, back, wherever I'm trying to continue to percuss. Okay? 50 to 60 percussions per minute. Now it's not this. Is that good? No. You got to work it. You got to work it. When you're going to be doing and performing chest physiotherapy and chest wall percussion on patients, remember what the purpose is. It's to move mucus. That's not going to move mucus. You've got to apply some oomph to your chest wall percussion. Now, being cautious on where we're percussing, right? If they've had surgery, I don't want to percuss over the surgical incision. If they have a painful, tender area, of course, I'm not going to percuss over that. I'm not going to percuss over bone, scapula, sternum, things like that. I'm not percussing over that. I'm percussing over lung tissue. Busty ladies, no, I'm not percussing over that. I'm going to have to work around those things to be able to apply chest wall percussion. Sorry, Jeremy. He looked disappointed. So you can kind of see this gentleman performing the percussion. How about this guy?
Like a conga drum.
Do you think you get tired? You do. At first, you're good to go. Eventually, your forearms start to get a little tight, start to burn a little bit.
Start slapping.
Yeah, because we're not slapping, keeping the cupped hands. In that rhythmic fashion. He looks way too happy performing CPT. I think the patient's humming, that's why he's kind of smiling. But yes, it can get exhausting, can get tiring. If the patient's going to be in that postural drainage position for how long?
15 minutes.
3 minimum to 15 minutes, and you're doing this the whole time. Wait till our lab. It's going to sound like a bunch of drums going off in there, right? Because we're all going to be doing that. We're all going to be doing that, doing it to each other. Again, making sure we're hearing that sound. We're not slapping a patient, right? Those cupped hands. There's going to be times you're going to have to, okay, this hand needs a break for a few seconds. Okay, let me get this one going, and then I'll be back at it again, okay? But we have to get the patient's chest wall moving to loosen up that mucus. I forget to mention something. All right, infant chest wall percussion. Now, depending on how small the infant is, I mean, their chest could be half the size of my cupped hand, so that's not going to work, right? They do make manual percussors, something like this. Now, notice these are open as you're applying and striking the thorax of the neonate. That is grabbing air as you strike it. And again, it's applying that air just like my cupped hands would. They even make kind of manual percussors. These are not the best pictures in the world, but they're open. Maybe your hands get too tired, but you're still going to have to apply that constant rhythmic motion throughout. And notice this little baby in the different positions that they're trying to do to drain those particular lobes or segments. Now, I'm just being honest. This gets exhausting. What if your assignment today, you had 10 patients to see, all 10 required of you manual CPT.
Request a new assignment.
Okay, you can take the assignment that has 15. It is exhausting. It is exhausting. It is tiring. You are going to have to pace yourself. And I say this to give every patient the best therapy possible. And I get it. I'm one person. Probably the first patient or two I do is probably that chest wall percussion is probably going to be better than patient number 9 and 10. And I hate to admit that because I want to give my best for every single patient. What if that was my loved one or your loved one and happened to be patient number 10? Again, I don't go in any particular order aside from who carries the highest priority because of illness or sickness. If not, if they're all about the same, then all right, let me not get fancy here. Bed 1, bed 2, bed 3, bed 4, until I clear my work list. But they do make, thank goodness, mechanical percussors that can apply chest wall vibration. Some are electric, get plugged into an electrical outlet on the wall. Some are pneumatic that get connected to an air or oxygen gas source. You could turn this button or turn that button and create faster, stronger vibrations that could be applied on the chest wall. Now, I will say one thing about these won't tire the way I physically will tire at a certain point. So that's perhaps an alternative. Again, I still consider this manual percussion, but again, with a mechanical percussor. Again, that won't tire, that won't wear out over time, like a human would. Now that's chest percussion. Again, when does chest percussion being applied? Inspiration, expiration, both? Both. All the above. Chest wall vibration is a technique that is typically not performed. It's chest wall percussion that's the most popular one, but chest wall vibration, and maybe it's the technique is a little different, and I'm always curious to see a new group of students practicing this for the very first time, seeing how coordinated you are when it comes to, number one, chest percussion, and then chest wall vibration. With chest wall vibration, you put your hands, your fingertips at the location you're trying to vibrate. Tell the patient to take a nice big deep breath in, and when they exhale, and only when they exhale, you apply the vibration to their chest. So and again, it's a technique that's a little unusual, right? Chest percussion is much easier. Just keep performing. I'm worried about inspiration, expiration or not. But chest wall vibration is only going to be applied during expiration. So you can tell the patient to take a big deep breath in. Now exhale. And when they exhale, throughout all exhalation, I'm applying that chest wall vibration.
Excuse me, can I ask a question? When will you use that instead of CPT?
I mean, this is still CPT,
No,
but chest vibration as opposed to chest percussion.
just because maybe you want to vary
You
the
could, I like that. You want to vary it up a little bit, try something a little different.
But serves the same purpose.
Yes, serves the same purpose, and I'm going to say one is not superior to the other. but I would say this one, technique-wise, is a little awkward. It's a little awkward. Again, not this, we don't have a lab this Friday, right? Not this Friday. Next Friday in the lab, we'll do a little bit of this, and we'll see, and I'll turn around and ask the question to you guys. Which one's easier? Which one's simpler? The percussion or trying to get that vibration? And the timing's not an issue. It's doing this the entire time to a patient. All right, so additionally here with CPT, we don't want, again, think about especially positioning of the patient. What if they're a little nauseous and I'm gonna put them on their head? And then, oh yeah, and then I'm gonna beat on their back a little bit and they're already a little queasy, already a little nauseous. If they've recently consumed a meal, I need to not perform CPT. If they have, and again, sometimes that's all timing, we will learn in time when the breakfast, lunch, and dinner trays come out. And trust me, at least I was one of those therapists that was like, all right, it's almost time for breakfast. I gotta get out there and get my therapy done. If not, what's gonna happen? Now I'm stuck, okay? The breakfast or lunch trays or dinner trays are out, and now I can't do therapy until everybody's done. I'd rather be done and have some waiting on the back end instead of waiting in the beginning, because you never know what's the next thing coming down the pipe. I never know when a code's gonna happen, and I'd rather have all or at least most of my work done so I do have that time to get away. But if they have recently consumed a meal, you need to wait at least 2 hours before you perform CPT because of the risk potential for vomiting and then aspiration. If they're receiving tube feedings, that still has to be held because that tube feeding's still going into their stomach. So that even has to be held. So something like this we would get with our friends in nursing and say, hey, can you turn that off? I've got CPT to perform. And you can't forget, again, they're not getting nutrition while we have this thing turned off, so make sure you get back there within that 2 hour or no sooner than 2 hours to then perform the therapy. All right, so CPT, limitations. Limitations. It does require that second person. This is something the patient really can't do effectively to themselves. Okay? Yeah, I can do my upper chest here, but I can't even get close to my back, let alone the technique would not be good. I need that second person. I need the caregiver. Now remember, this could be performed in the home too. We can teach the family to do this. We can teach mom and dad to do this to the cystic fibrosis child. We can teach other family members, older brothers and sisters, grandparents, aunts, uncles to do this in the home. So it's no special technique that could not be taught. But it does require a second person to perform this. It may be, CPT's effectiveness may depend on the positioning. So sometimes we do have to modify the positions sometimes. Patient tolerance is a huge deal. Some patients just are not comfortable in some of these positions. So sometimes positions have to be modified. And if we can't modify them, then maybe we should try a different airway clearance therapy technique. And maybe CPTs is just not in the cards for this particular patient right now. Patients who are already short of breath, and do you think we deal with patients who are short of breath? All the time, of course, all the time. Patients who are already short of breath might not tolerate. And the Trendelenburg position, what's Trendelenburg? Which way is down? Head down, Trendelenburg. So patients who are already short of breath might not tolerate it with their head being placed in that downer position. It may make them feel even more short of breath. And so again, that creates limitations on some of the positioning that we could put that patient down in. Additionally, to achieve maximum secretion drainage, positive drainage and percussion with the head down positions should exceed 25 degrees below horizontal. But if my patient has an elevated intracranial pressure, those head injury patients, and you put them on their head, you increase blood flow going to the brain, and you're already worried about elevated intracranial pressures, you can make it 100 times worse. So again, things that do have to be taken into consideration with the postural drainage position, the postural drainage part of CPT. And like I said, If the patient can't get in the right position or close enough to the right position, then maybe CPT and postural drainage is just not in the cards for them. Maybe there's something else we could try instead. All right, contraindications. Head and neck injuries until they're stabilized, that's an absolute contraindication. They have bigger concerns than some retained secretions right now. So until their head and neck injuries are stabilized, if they're actively hemorrhaging, actively bleeding, and hemodynamically unstable, another absolute contraindication. That intracranial pressure issue that I mentioned before about being in that head down or Trendelenburg position. Again, normal intracranial pressures are generally less than 10, a single digit. Considered a contraindication if it's greater than 20. To again, place them in these positions. If they've had a recent spinal surgery or an acute spinal injury, again, this is probably not the best time to do chest wall percussion and put them in those positions. Rib fractures, if they're a trauma patient, and again, picture you have some fractured ribs and somebody's gonna do this over it. Yeah, no, that's, we're not gonna, let's try something else. Let's do something different for this particular patient. Pulmonary edema. Now, pulmonary edema, think about what pulmonary edema is. Fluid overload, pink frothy sputum. Sure, I could probably put the patient on their head and have some of that stuff drain out, but this is not the appropriate therapy for that condition and that situation. So even though pulmonary edema is excessive fluid in the lung, excessive fluid in the alveoli, postural drainage and CPT is not, absolutely not the therapy to try to correct that. There's other things for that we'll talk about in due time, but this is not one of them. How about a confused or anxious patient? Horrible, horrible. You have a patient who has dementia. For 5 seconds, they understand completely, and then you get them in a position and they, what the hell are you doing? What the hell? And then you start doing this. Again, doesn't make for a good situation, right? Doesn't make for a good situation for a confused, combative, or anxious patient. There's a whole lot more that I just didn't have room to put here on the slide, so just kind of referencing, you can glance back at box 44.4. I forgot to write down the page number, but regardless, for the full and complete list. But these are just a few, some of what I would consider kind of the more important ones to note. Now, complications that could occur. Hypoxemia. Again, you have the patient perhaps on their head, you're doing percussion, they're already borderline short of breath. You could make them hypoxemic. So maybe this is something, if they're wearing oxygen, do you keep them on their oxygen or do you take them off? No, I leave them on their oxygen. Their 2-liter cannula, 4-liter cannula, whatever their device is, yeah, I would go ahead and just keep them on that, knowing that they could have some degree of hypoxemia during the therapy. Increased intracranial pressure for the third time being mentioned here, yes, and that's more related to the position, not necessarily the percussion. Pulmonary hemorrhaging, pulmonary bleeding, that could be from the physical act of just coughing. And again, with these patients, maybe they've been coughing and trying so hard to get that stuff out that now they're coughing up some blood, because again, they're straining, they're really coughing so hard. Acute hypotension, hypotension means low blood pressure. Pain, of course. I would always suggest when you're performing this on a patient to make sure the patient understands, hey, if this hurts or if this is uncomfortable, please let me know. And again, because I try to be aggressive when I do this, and yes, if it was a younger, bigger guy, I'm probably going to wail on him a little bit harder than I would for a little 90-pound grandma. But I'm still I want to get secretions moving, right? So always make sure when you're doing this to make sure the patient understands, hey, you can tell me if this is uncomfortable, if this is too hard. I'll never forget this cute little lady I did CPT on one day. She was the sweetest thing. She was more than willing to let me perform CPT on her and put her in the right position and sit there, and I probably told her 3 or 4 times, now you let me know if this hurts. You let me know if this is too hard. And she's okay. And we're going, and I'm feeling accomplished because I'm getting them secretions out of this lady's lungs, right? When we were finished, and I sat her back up, and I said, doing okay? She goes, yes, but can you help me to the restroom? And I said, of course I can. She goes, because you beat the piss out of me. I got scared. I'm like, you were supposed to tell me if that was too hard. And she goes, no, honey, I'm joking, but I do have to pee from being in that position so long. But I'm thinking, oh my God, did I really hurt you, lady? But she was the sweetest thing as can be. The worry of vomiting and aspiration during this is high, especially if they're going to be in some awkward, kind of funky head down position. Bronchospasm could occur. Arrhythmias even could occur. Be kind to the folks that are watching the patient. If the patient's on a heart monitor, be kind to the person who's observing that, because every time you do this over the lead, it's going to show artifact, and it's probably going to look something like this, which I know as a class we haven't talked about this yet, but it looks a lot like ventricular tachycardia, which I shouldn't tell you my stories here.
Yeah, we got a 200-beat run of VTAC going on.
Right, so prior to, you probably want to hit the nurse call button. Hey, just so you know, I'm going to be in here doing CPT for the next 10, 15 minutes.
Call them on.
Just so they are aware, just so they know. Again, you'll find out my sense of humor here. This has been several years ago, many years ago. I was coming home from work one day and I felt what I thought was chest pain. And I'm like, this is unusual, this is not good. And so the closer I'm getting home, I'm like, this isn't right. I need to go in. And you know the number one thing in an ER when you walk in there and you have the complaint of chest pain or shortness of breath. All right, right here, sir, you bypassed the line. You know, really, I just stubbed I got an ingrown nail. Can somebody cut that? No, never do that. So anyways, I got fast forward in the line. Well, to make a long story short, I was fine. It was nothing cardiac. But they had me on leads so they can constantly monitor after, and my wife met me there and everything. So again, nervous initially, thinking, oh, I hope this is nothing cardiac. I hope this is nothing serious. And like I said, which it wasn't. But now I'm in here. Gotta wait, and been there for hours, and me and my awkward sense of humor and my ability to get bored very easily, because I could see the monitor tech where they were sitting, and I could see, again, they have a million monitors and everybody's leads are there, and he's looking and he's looking, and my wife's getting on me. She's like, stop, would you stop? It's all right. And when I noticed his eyes glance up, I could tell, okay, I know what monitor's mine. I'd stop, and he'd look, and back to his thing. Yeah, my wife's ready to kill me. And at that point, he's looking at the monitor, and then he looks up to see me in my room. Dork. Yeah, just, hey, it's me, sorry. But those things, again, depending where the leads are, you start doing CPT on your patient, yes, the monitor does this, which looks a lot like ventricular tachycardia, a potential lethal cardiac arrhythmia. Yeah, bad. All right, so just a few things here. If you observe during chest physiotherapy any adverse event, remember what they say here, the triple S rule. Stop the therapy, number one. Return the patient to their original position, which again, think about it. If they're in that head down position, you want to sit them up. There's another S. Sit them up, stay with them until they are stabilized. So they're having an adverse reaction, it's all right, we're still going. No, you need to stop therapy. And I think that's true with any therapy. If there's an adverse reaction, whatever therapy you're doing, you need to immediately stop. Yes?
So for the acute hypertension, is it because like all the blood's like rushing?
It could be. It could
So
be.
they're
It could
having
be.
lower blood pressure.
Yep. Now, most of the complications are not related to the percussion. It's related to the positioning of placing that patient in that head down position. All right, so when we're finished performing CPT, chest physiotherapy, what's the next thing we're going to have the patient do? Cough, thank you. So there is some different coughing techniques that could be taught. Again, I could simply say, can you go ahead and cough for me? They may cough and they're turning blue in the face, they're trying to cough for you so well, and they're still not bringing anything up. So there is a couple of tricks, and again, they're looking at us as who? The expert, right? So you talk a good game on coughing, you may get them to cough, and suddenly you really didn't teach them anything that they wouldn't have done anyways to cough, but it just sounds different coming from a professional like you. So the term directed cough, okay, directed cough. Having the patient take a good deep inspiration, like we should before any time we cough, and have the patient bear down against their glottis, okay? So the glottis is here. Without trying to be disgusting here, if bear down during a BM, you're closing down the glottis. If you're lifting a heavy weight and you're trying to push, you're bearing down against a closed glottis. So that's what that kind of technique is. Yeah, I won't use the bathroom analogy for my patient. I'll say, if you've ever lifted a weight, a heavy weight, and you're trying to just bear down to get that weight up or to get that bar off your chest, you know, that's kind of bearing down against a closed glottis. But again, starting with a good deep inspiration first. This next one, the forced expiratory technique, also referred to as the huff cough. The huff cough. You can even have the patient say when you cough, say huff, huff. The huff cough is different than the directed cough. This time you're keeping the glottis open. Okay, you're keeping the glottis open. That's why when you can say huff, your glottis is left open. It's creating a little bit less pressure that may work for some patients, some individuals. Again, but still taking good deep breaths. This next one, this third one, autogenic drainage. This is coaching the patient to breathe with 3 different phases or 3 different levels. Okay? So focusing on using the diaphragm to breathe. Again, where's your diaphragm? Right here, right there on your belly. Focusing on the diaphragm to breathe. You can tell the patients, hey, when you breathe in, think about it, your diaphragm goes which direction? Up or down when you inspire? Down. It goes down. So you could say, tell the patient, put your hands on your belly. When you take that good deep breath in, your belly will poke out a little bit. It's your diaphragm going down, okay? When you inhale, you should feel the abdomen kind of sink in because the diaphragm's going up when you exhale. But get them to kind of put both hands there on their abdomen, on their belly, and have them focus on using that muscle to breathe. Using that muscle to breathe. When they do the technique, again, the first phase, so this is actually the lung volume capacity chart minus the labels, right? So you can have them start by taking a good, big, nice deep breath in, exhale, and I don't want to call it shallow breaths, but if this is supposed to represent tidal volume breathing, they're getting a little less than that. They refer to this as the unsticking phase of the autogenic drainage coughing technique. The second phase, they're going to breathe a little bit deeper. Still, this is tidal volume from here to here, so they are breathing a little bit larger, moving a little bit more air than they would during a normal tidal volume breath. They refer to this as the collection stage. Final stage, you can see they're taking definitely some deeper breaths. They call this the evacuation phase, which then the last step of this will be coughing. While they're doing the different breathing maneuvers, these different breathing phases, we should tell them, do not cough. Try to suppress your cough until you've done all 3 breathing phases. The other examples we gave, during CPT, you feel the need to cough, patient, go ahead, cough. I'll pause for a second, let you get that stuff out, and if we need to sit you upright so you can cough and clear, yes, I can do that for you. Coughing is fine during any of these other therapies. This one in particular, we should tell them to suppress their cough. Don't cough. I know you may feel the need, you may have some secretions that's starting to unstick in the airway, and you may feel the need to cough, but try to suppress it if you can. If they can't, it's not the end of the world. Clear what you can, we'll start back over again. But really, they should try to not cough until all 3 phases have been complete. And then again, after phase 3, what's the next step? Cough. Have them go ahead and cough at that point. Questions? Is that my last one?
Yeah.
Okay. All right, so CPT, which includes percussion, vibration, postural drainage, the different coughing techniques. Directed cough, the forced expiratory technique or huff cough, and then autogenic drainage. Okay. Next week, Monday, we'll go over pretty much the rest of all of the bronchial hygiene devices. I'll get that PowerPoint posted here real soon so you can take a look at that ahead of time. I did post a couple of videos in Canvas. Again, nothing that we talked about today, but some of the stuff we'll talk about on Monday. So you guys can, if you want a little head start looking at some of the things we'll be doing. All of this, today's discussion and then next week's discussion, we will then all lab that plus the lung expansion therapy that we talked about on Monday. All of that will be in that last lab. Not this Friday, but the Friday after. The 14th? No, not the 14th. 21st. 14th, we don't have a lab. It's the 21st, that next Friday. All right, questions? Yeah.
If we do a chest percussion,
Mhm.
that the duration is 3 to 15 minutes, do we have to make them cough in between of that, or just one time coughing at the end?
I would, for that particular example, I would say cough whenever you feel the need. Okay. And again, that 3 to 15 minute is for the different positions that I place the patient in. So just depending on how many segments we're draining or how many lobes we're draining, it drives me crazy, and I'm just gonna be honest here, it drives me crazy when a physician orders CPT Q4 hours. Okay, doc, where? Everywhere? Yeah, go ahead. Okay, sure. At that point, I would want to see what the x-ray looked like to see where is the problem. Is it the right side? Is it the left side? Is it just the bases? Is it everywhere? I doubt it's everywhere. This is not an ICU patient. But to know where, what specific lung segment and or lobe, or at least give me a lung, doc. Tell me if it's the right lung or the left lung. At least narrow it down a little bit for me. But it does drive me crazy when a physician orders CPT-Q4 or CPT-Q6 or CPT-QID. Those different frequencies. Okay, but where? What am I trying to focus on when we do this? Okay, because again, postural drainage positioning is going to depend on what I'm trying to drain. So CPT in a single position could potentially be 3 minutes or so. But again, remember, be fair. Was that enough to get this patient's secretions moving? They can tolerate 5 minutes, 6 minutes, 10 minutes. 15 minutes is kind of the extended part, even though, and I'm just tell you, CPT 30 minutes for your cystic fibrosis patient. For that, I said 30, not 3, 30 minutes. Now I'm going to tell you, am I going to be able to continue this pace for 30 minutes? Start throwing elbows and knees to try something. I'm joking. But maybe some other techniques to kind of assist. Or if this is a cystic fibrosis patient in the home, and maybe mom, dad, brother, sister can tag out and switch so the child's getting good quality CPT for that 30-minute time frame. Or some of the stuff we'll talk about on Monday.
They sometimes use the mask. Does that help, or
Okay,
mask?
I should have put that on here. The AMBU or resuscitation mask, that would capture and grab hold of air. The only thing I would add to the mask is that open end that you would connect your resuscitation back to. Get some tape and tape it over. That works perfect. So that kind of mimics my hand. I'm still having to hold that and apply it and strike the patient's chest with it. And I can get going like bongo drums. I can get going and do that percussion, but that would work too. All right, any questions? I do have a couple of questions for you guys. All right, so question number 1. At what point during chest wall percussion therapy should percussion be applied? Inspiration, expiration, both inspiration and expiration, or after inspiration but before expiration? I'm a fan of D myself, so during a breath hold, I don't know. No, C is the correct answer here. But let me change up this question for you guys for just a second. I replaced the word percussion and I replace it with vibration. Then what's the answer? Expiration only. Okay? The way it's written right now, C is the correct answer. But if I take out the word percussion and replace it with vibration, expiration would be the correct answer then. Everybody okay with that one? All right, next question. Which lung segment will be drained if placed in this postural drainage position? So options are anterior segment of the lower lobes, posterior basal segment, posterior apical lung segment, or anterior upper segment of upper lobes.
Posterior
B, I keep hearing B or posterior basal segment. B is correct, the posterior basal segment. Again, head down, patient prone or on their stomach. All right, everybody okay with this one? This one was B. Next question. What if they're in that position? That almost looks like the position some of you guys are in right now, kinda. Right? If you're sitting upright, big and tall. Posterior apical lung segment. So this one is C. This one is C. Posterior apical lung segment. All right, so just be able to recognize, I may give you some pictures on the test, and ask a question just like this. I may verbally describe the position and not give you a picture. That's what I mean. Make sure you understand the word prone, they're on their stomach. Supine, they're on their back. On their right, on their left. Trendelenburg means what? Head down position, right? What about reverse Trendelenburg? So feet down, and the head's up. What do they call this position? Oh, there you go, Fowlers, high Fowlers. Sometimes, I think if the way you guys are sitting right now, I would call that high Fowlers. If you lean back in your chair a little bit, maybe 45-degree angle, semi-Fowlers. All right, I think I have one more. All right, God bless you. Which of the following is a contraindication for postural drainage? Cystic fibrosis, COPD, unstable spinal injury, or chronic bronchitis? Contraindication would be C. You know, CF, COPD, even chronic bronchitis for that matter, could all benefit potentially from postural drainage or CPT, chest wall percussion, airway clearance therapy, whatever other things you want to call it. All right, short, sweet? To the point? Okay. It's not difficult. I think the hardest part, or the most challenging, I don't want to call it hard, the most challenging part is all the damn positions. All those damn positions to sit there and place the patient in to drain. Just don't confuse. And I'll leave you with this. If I'm trying to drain something on the right,
Place them on the left side.
the right side is normally the side that's going to be up. If it's something on the left, it's the left side that's going to be up. If it's the right side, I'm not putting the right side down. If it's the left side, I'm not putting the left side down. Because again, you're trying to drain this stuff where? To the central, hopefully the central airways for the patient to be able to cough and expectorate and bring that stuff up. All right, just make sure. Okay, that was the last slide.